Up and it's really a pleasure to be with all of you. And I must say, the talks have been absolutely brilliant, and I've learned a lot, and I really congratulate all the speakers for what I think has been a really superb session so far. Okay, let's see if we can get this to go. So what do we know about toric IOL calculations? And because you've heard so many good talks, you're going to hear some repetition compared to, you know, what I'm pointing out here. So what's our threshold for correcting astigmatism? I think it depends on the patient's needs, but for a monofocal IOL, it's around a diopter. For a multifocal IOL, however, we need to be within a half diopter or less of accuracy. And the reason for that is we're combining two sources of contrast loss with when we're using premium IOLs. We have, of course, our old friend, the conoid Sturm for astigmatism, which means that light is not focused at any one given point when there's existing astigmatism. And then we have what I call the cone of multifocality with a multifocal or even an extended depth of focus IOL, where again, the light is not brought to any given one point of focus. So when you combine these two, the conoid Sturm, and you superimpose the multifocal IOL on it, you can see that the blur circles get larger for any of these various iterations of astigmatism when you have a multifocal IOL combined with astigmatism. So, and this was shown beautifully by one of the many wonderful studies done by Hayashi, where they took the Restor 3-diopter lens and they added a half diopter of astigmatism, and they saw a dramatic drop in vision from 2020 to 2030. So we need the astigmatism less than a half diopter. Now, what about surgically induced astigmatism? It's a lot more complicated than we have thought about. I operate temporally, and with my 2.4 millimeter incision, my mean, that means the centroid on the double angle plot, the mean astigmatism was 1/10 of a diopter. So that's what I use. But there's a lot of scatter in the data, up to 0.8 diopters. And that means either our devices aren't measuring accurately, or truly there are some patients who get an unusual amount of surgically induced astigmatism. And this is only in the anterior cornea. So I use 0.1 as my baseline for my toric calculations. You can calculate your surgically induced astigmatism with many websites, including Warren Hill's here, the SIA calculator. And now we have a way for you to calculate it on the ASCRS, ESCRS, and JCRS websites with a corneal SIA spreadsheet that Adi Abalafia has done. Well, but SIA is more complicated, and a paper from Jack Holladay and George Pettit recently really makes the point that surgically induced astigmatism really is the postoperative refractive astigmatism minus the preoperative corneal astigmatism, whether it's anterior or total. And the SIA includes a lot of unknowns: posterior corneal surgically induced astigmatism, lens tilt, other things. Ultimately, we'd love to know what each one of these is so we can measure each precisely. But right now, we really have this kind of crude or kind of grouped number of post-op refractive astigmatism that includes so many things, and we compare it to the pre-op. And it's interesting that the data that he presented in that really confirmed the accuracy of the original Baylor nomogram that I published. So we've talked about, and we've had great talks in keratometry and topography using 2, maybe 3 data points, the lens star and the IOL master, and now the Anterior for power and meridian primary. But topography is very helpful for alignment. I don't rely on topography as much for the corneal power, but I really rely on topography by using placido-Meyers. I think placido-Meyers are essential in my practice for evaluating the corneal surface because I can detect subtle abnormalities. And interestingly, sometimes the glasses give you clues about the patient's, perhaps it's the lens tilt, because you may see in the prescription of their glasses less with the rule astigmatism or more against the rule astigmatism, suggesting there might be some lens tilt. And whenever there are discrepancies in these measurements, I remeasure them, and if they continue to have discrepancies, then I will not correct the astigmatism at the time of surgery. I'll reevaluate with a good refraction after astigmatism. So we've heard about data analysis, and here's a good example. This patient came to me for pre-op, K readings 4334, astigmatism 2 diopters at 174. The IOL Master 700 did not give me any K readings. And you can look at the reflected Myers from the IOLmaster 700, and you can see there's a missing data point right here. And here are sequences of IOLmaster 700s, and I finally got 2 measurements with this patient but still without good, here's finally one with a data point there. And then I went back and I looked at the patient's exam 3 months previously. The Galilei said that the mean corneal power is 44.6, but the Lenstar at the time he presented for surgery was 43.34. And the astigmatism that I had gotten with the Galilei was 1/10 of a diopter as opposed to 2 diopters with the Lenstar. So it shows the amount of error that can be introduced, and these are the Myers from the LEDs of the Lenstar, showing the same sources of error in the same consistent area infratemporally as we saw with the IOLmaster 700. And when I treated the surface and repeated the measurement 6 days later, everything lined up, all the K readings matched. He did not need a toric IOL. I put an EDOF and he had a great result. So we do need more than one measurement, but as important as that, we really need to verify the quality of our raw data. And we can do it qualitatively by looking at the Myers, whether it's those Myers that you have with the IOLmaster 700 and the 18 LEDs or the Lenstar, or as was shown so nicely, even with the IOLmaster 500, or you can use your standard deviations. And Warren Hill has shown us, for example, for the Lenstar, the standard deviation that you want to get is no more than 3.3 diopters for the corneal power, steep or flat meridian, and 3.5 degrees. So how do we factor in posterior corneal astigmatism? Well, we know that posterior corneal astigmatism tends to be steep vertically, and it contributes to against the rule refractive astigmatism. That's in 80% of the eyes. In the other 20% of the eyes, though, the posterior corneal astigmatism is either oblique or actually steep horizontally. So we can incorporate it into our toric calculations by using regression formulas or by directly measuring the posterior corneal surface. The regression formulas, we started with the Baylor nomogram, the Barrett, the Abulafia Koch, the now J&J, and then the Alcon toric calculator, which is in fact the Barrett. And they're getting about 80% within a half diopter with that. We looked at our data. Let me make the point that Graham Barrett has talked about using 3 values, and Sri Ganesh mentioned that earlier. That's an excellent approach, and he uses the mean of these 3 values. And I think this is particularly useful for people who, as surgeons, may not have a lot of time to study the data, and they want to use a sort of a formula that can be done by their technicians and given them. And Graham did show slight improvement in accuracy with this. My preference, though, is really to pick the best measurement. And by best, I mean I look at the reproducibility and I compare it to other measurements. So I look at each one separately and pick the best one. And with that approach, we've been pretty accurate. So the problem, though, with all of these sort of formulas that don't measure the total corneal power is that there's variation in posterior corneal curvature. This is a map of or a graph of the anterior corneal curvature astigmatism, and in patients with the rule astigmatism, and this is the posterior corneal curvature measured with a Galilei. You can see there's a lot of variability. Here's the regression line, but we have patients all over scattered around way up here. So there's individual variation, and of course, in complex eyes, post-LASIK eyes, the relationship between the front of the cornea and the back of the cornea is lost, and we really can't use regression formulas for that. And of course, in those eyes, it's also challenging even to measure the anterior corneal curvature and understand what values to use for our toric calculations. So my own data using the Baylor nomogram and the Abulafia Koch, we've in hand-picking the power, the particular measurement, we got 93% within a half diopter. But that is a time-intensive activity. So does direct measurement of posterior corneal curvature improve our outcomes? We're always asking that question. Can we get rid of those regression formulas and use a direct measurement? And we can measure posterior corneal curvature using Scheimpflug devices, but all of the data that I have seen show no benefit of measurement with Scheimpflug devices. In fact, they don't perform as well as, for example, the Barrett or the Abulafia Koch. OCT devices, we have many of them now, the swept source OCT devices that are measuring the posterior corneal curvature, and I'm really going to be interested to see what the Anturion does because of its measuring so many different meridians. It's going to be really exciting to see what it comes up with. And we already heard that the 700 IOL Master 700 measures at 6 meridians with, and it adds the total corneal thickness to the anterior corneal curvature in order to get total corneal power. So another approach that's interesting is to actually use reflection base, which is what we use for the anterior cornea, reflections of LEDs. In this case with the Cassini, the color LEDs measure the anterior corneal power and curvature. But the white LEDs that you see here, these 7, can be actually detected as the reflection off the posterior corneal surface. There's the anterior corneal, this is the posterior corneal. And I think it's going to be interesting as this technology evolves, and it's continuously improving, whether or not this might prove to be most accurate, because we do know that reflection technology for the front of the cornea, at least up until this point, has proven to be the most accurate way to measure anterior corneal curvature. There aren't a lot of data yet on using total corneal power with the IOL Master 700. Graham Barrett had reported on a few cases for post-LASIK eyes, and he showed that he got 68% with a half diopter using True K, but 75% with a half diopter using the True K Toric in these post-LASIK eyes, so that measuring the posterior corneal curvature did help to improve his data. So our own data in looking at the posterior corneal curvature with the IOL Master 700 shows some improved accuracy in our toric calculations in eyes with against the rule astigmatism, but we did not see any improvement in eyes that had with the rule astigmatism. So we're learning still about what's contributing to surgically induced astigmatism and what really needs to be incorporated into our toric IOL calculation formulas. Direct measurement's getting better. It's where we want to go, but at best, it's still marginally superior to our regression formulas. What about intraoperative aberrometry? Well, I rarely use it actually for toric surgery. It is useful for those who do fewer preoperative measurements. It has a value. I think it has an upper limit to its accuracy because of all the factors we know measuring an eye after surgery has been conducted with altered corneal surface and corneal thickness and so on. And I think its role will diminish as our preoperative technology improves, and I think we'll see it someday become obsolete, but it still plays a nice role for many excellent surgeons. How do I align my toric IOLs? Well, you know, I'm still kind of a manual marker. I do like the Callisto, as I'll mention. We know that you have to align your toric IOLs within less than 10 degrees because a 10-degree misalignment introduces a 33% error. I like to make a pre-op drawing if I have one where I can draw some vessel, but on the day of surgery, I sit the patient up. I make marks at 3 and 9 o'clock, but my marks are rarely, if ever, exactly at 3 and 9 o'clock. So I make a note of where these marks are on a drawing. I take this to the operating room with me, and I then use that to align my toric IOL so I know exactly where I'm aligned. And when we did that, we found accuracy, a mean accuracy of better than 3 degrees for all of our toric patients. We've heard about the high-tech options, the Callisto, the Varian, and again, we got as good a result for my kind of obsessive compulsive manual marking. That said, I love the Callisto. It's wonderful to have it right there in the operating room and to align the toric IOL with that, and we're kind of moving more and more to that technology. I think that we're going to eventually ultimately migrate to that because it is faster and easier, but I'm not sure really, if you're really compulsive about your marking, it's that much better. What about post-LASIK eyes? I think this is interesting. We just reported this. Toric IOLs in our hands work out very well if you meet 3 criteria. You want a regular bow tie astigmatism within the central 3 millimeter zone, whether it's post-myopic or post-hyperopic LASIK. The difference in a corneal astigmatism in our study was between the IOL Master 700 and the LensStar, but it can really, I think, be between any of your measuring devices. If it's less in magnitude than at 3/4 of a diopter, as it is in this data set, and if the difference in the steep meridian is less than 15 degrees. And what I did in this, when I did these calculations, is that remembering that the surgically modified cornea doesn't tell you anything about the posterior corneal astigmatism. So for these eyes, I just estimated it was 0.3 diopters against the rule. And I targeted with the rule eyes for a little undercorrection. I leave them a little bit with the rule. Oblique eyes, full correction of astigmatism. And against the rule eyes, a little overcorrection, again, to leave them 0.3 diopters with the rule. Factoring all this in, we got in post-myopic LASIK eyes, 56 eyes, 80% within a half diopter, and post-hyperopic LASIK, 84% within a half diopter of refractive astigmatism. So that's actually been published now. What about keratoconus? Well, and radial keratotomy. In my mind, they really fit the same sort of criteria. They have to be stable. You have to have regular topography in the central 3 millimeters. You're not going to be wearing a contact lens post-operatively, and it's very important to sort that out with the patients. You don't want to put a toric lens in if they're going to wear a contact. And the spectacle correction with its astigmatic correction before the cataract, or when you can get a good refraction, gave good vision. If these, if the spectacle astigmatism and the topographic and the biometric astigmatism line up relatively well with either RK or keratoconus, I'm pretty comfortable using a toric IOL, and we get good results with those. But I think that's what's interesting. It'll be interesting, I think, as this technology for keratoconus improves. I think ray tracing has a huge potential here because of the fact that it really will take into account all of the odd aberrations of the anterior corneas of these irregular, of the anterior corneal curvature in these irregular corneas. And of course, I think a very interesting approach for these corneas with advanced irregular astigmatism are things like the AcuFocus IC8 that you can put inside the capsule that are used in a lot, have been used with good success, particularly outside the US. Hopefully we'll get it soon in the US. And the Morcher Extra Focus is developed by Claudio Trindade in Brazil, and then made by Morcher. It's a very interesting add-on technology for treating irregular corneas. So what do we still need in our calculations for toric IOLs? Well, as I mentioned, we need better keratoconus, RK, post-keratoplasty measurements of our corneas that include the anterior and posterior cornea. We need to factor in IOL tilt, and I'm hoping that our new formulas will ultimately get there. We can measure the IOL tilt with the IOL Master 700, but unfortunately the data have to be sent to Carl Zeiss in Germany to be analyzed. And we did a study. The first one came out from Oliver Shindo and Nino Hernschel, a wonderful paper. And we subsequently published a study that found that the crystalline lens tilt was 3.7 degrees, but up to 7 degrees. And this shows of the 6 cuts with the IOL Master 700, this shows the cut with the most tilt. And this actually is the horizontal cut. And you can see that this is the nasal side and this is the temporal side. So the crystalline lens is tilted with the nasal side anterior. Why is that? Well, it's because the eye's turned out a little bit. And why is the eye turned out? It's because of the angle alpha. And why angle alpha? It's because we are placing the image on the fovea, and the eye has to rotate to bring the image onto the fovea. IOL tilt, interestingly, is more than lens tilt, up to 10.7 degrees in our study. It's nasal anteriorly. And what this does in this tilt is it actually induces plus power along the horizontal meridian. It's another cause of against the rule refractive astigmatism in our patients. So can you predict the IOL tilt from pre-op? And in 65 eyes, the pre-op was 3.6 up to 6.7. Post-op in these 65 eyes, 4.8 up to 9.3. And the tilt direction, this is the magnitude of the crystalline lens and the IOL. The tilt direction and magnitude is predicted by the pre-op crystalline lens tilt. So I think this is really exciting, and it's something we're going to see incorporated into our formulas. As we get better, we had a high R-squared of 0.5. And here's one patient, crystalline lens, IOL. You can see the similarity in the tilt. Well, what's the impact of this? Well, the impact, if you have a small amount of tilt of 5 degrees, it really doesn't induce much astigmatism. This is induced astigmatism from IOL tilt, in this case of a toric IOL. And you can see it's less than 0.2 of a diopter, but it is still some. But if you have one of these eyes that has a higher amount of tilt, let's say 9 degrees, you can get induced astigmatism of up to 0.6 diopters. And it's interesting too, and important to know that if you're aligning your toric IOL at 90 degrees to correct with the rule astigmatism, you get an increased effect of that IOL toric correction. So it creates more against the rule change. And conversely, you undercorrect if you're aligning the IOL at 180 degrees. So this is going to come into play as we move forward. I think we're really going to need a way to deal with so much data and prevent errors. We're overwhelmed with data. The point was made, there's a sort of diminishing returns about one measurement after another after another. And I think with so much data that we're acquiring, all the data entry, we need things to automate it. And I think programs like VERACITY and others that are in development are going to really be important for us going forward. And this is just an example of this one program, VERACITY from Carl Zeiss, where it imports all the refractive data, look at all the K readings that are incorporated here. You can then have a surgical plan that you can take to the operating room, and then actually you can just post this on your screen so you know exactly what lens you're putting in for a given patient. And then you can generate operative reports and do a lot of things with it. I think post-operative adjustment is going to be important, whether it's something like the RX site technology or localized refractive index change, refractive index shaping with companies like Perfect Lens and Clario. The beauty of this RX site is that it's incredibly accurate, but you must use their material and their lens. With Perfect Lens and Clario, if it ever comes to fruition, you can do it really on any IOL. So I want to close by talking a little bit about how we analyze astigmatism outcomes. Astigmatism is complicated. Astigmatism has two variables, power or magnitude. And you can't, so let me just pause that here, go back here. Okay, you can't solely or add or subtract values when you're analyzing astigmatism. You can't analyze vector magnitude alone, and you can't analyze vector angle alone, as is done in a program like a SORT. You have to combine them, because if you don't use the two variables together, you can get misleading results. So, so you can't oversimplify it. When you analyze astigmatism, we break it down into two variables, the X and Y components. We perform calculations on them separately, and then we reassemble them back to the astigmatic value. So how do we make it more straightforward? We want intuitive terminology. We want data that are clear and complete. And in our guest editorial, we proposed simple terminology, and we described the figures that we think are used or needed to best display our astigmatic outcomes. Surgically induced astigmatism can be described as the predicted, the actual, and the prediction error. The components are the corneal component, the IOL component, and the total. And those are very simple terms. And for IOL surgery, it's the predictive post-operative refractive astigmatism, the actual, and the, so we have these are the same terms we use for evaluating IOL calculation formulas. And our spreadsheet creates three figures. There's a cumulative histogram, percentage of eyes within certain amount of dioptric error, which is, of course, the bottom line for what we want with our corrections. And then we have, how do you display it with both magnitude and meridian? And you can do it with single angle plots or double angle plots. This is a single angle plot, very intuitive because it looks like our 4-opter. But if you take those with the rule and you double them and move them around, and the against the rule and double them, then we group all of the data together so that we have, as you can see, with the rule here and against the rule here. And that's a very attractive way to group the data once you understand that the with the rule are to the left and the against the rule are to the right. It just requires us to kind of rethink how we look at these images. So here's a single angle plot of some data. Looks like a 4-opter, but you don't really know what the data show. With the same exact data points, double angle plot, you can really see that they're grouped on the against the rule side. Remembering this is the 0 side, the against the rule side, this is the with the rule side. And here, for example, here's a data set of pre-op corneal astigmatism, post-op refractive astigmatism. You can see how elegantly it shows the 95% confidence ellipse for the pre and post-op data and the centroids of the data in that data set. And so you can look at pre and post with this. We generate a lot of data from it. And Very importantly, you can look at the prediction error, which I think is what's so important. This is the prediction error of a toric IOL set with just using anterior Ks. You can see that it has an error on the against the rule side. And when we introduce a formula like the Abelafia, Koch, or the Barrett, you can see that all of a sudden we have a centroid that's moved from against the rule here to with a centroid amount of 0.55 to right around 0. But notice the standard deviation is just as large, but a very nice mean correction of the astigmatism. And the percentage of eyes within a half diopter goes from 31% to 77%. This spreadsheet is available, very easy to use on the ASCRS, JCRS, and ESCRS websites. Here's where you find it on the ASCRS website. Very easy to find and very easy to use. I think the double angle plots are highly informative. They're easy to understand, but you've got to grasp the concept that of the doubled angle, that the with the rule eyes are grouped over here to the left and the against the rule eyes are grouped over to the right. And I believe that this is the optimal way to display astigmatic data. So looking back then and thinking about our toric IOL patients, I think it's going back to the patient, him or herself. It's really important to hear patients' visual complaints postoperatively. And we have to learn, of course, to be not satisfied with subpar distance or near vision in these patients. We have spherical error, we have astigmatic error. And one thing we may not have a chance to cover, but of course it's so important to be willing and ready to treat any errors you encounter. And I want to thank you for your attention and for the real honor of speaking to all.